Welcome to part 2 of Practical Management of Desmoid Tumors. This is medical oncologist Dr. Neil Love. I met with Dr. Ravin Ratan from the MD Anderson Cancer Center in Houston, and on the initial segment of the program, we did a mini journal club reviewing a number of important recent publications and presentations on this topic. And on part 2 here, I asked Dr. Ratan to comment on a series of cases presented to me by two other oncologists from MD Anderson, Drs. Elise Haddad and Michael Nakazawa. To begin, Dr. Haddad presented one of the most interesting cases ever presented in all of our CME programs.
This is a 40-year-old female patient who had a diagnosis of a big pelvic mass that was made on intense nausea and vomiting. Majorly biopsy-proven desmoid, and it measured 10 times 12 centimeter in her pelvis. And so to get it out would require a major surgery with a real risk of recurrence. And so what I initially discussed with her was initiating systemic treatment with nirogacestat. The patient chose to do active surveillance with symptomatic treatment because we also counseled her that 30% of patients have spontaneous regression of their desmoids. She was a 40-year-old female patient who did not have kids yet and wasn't entirely sure if she was going to want kids in the next couple of years and was very fearful of the ovarian insufficiency because even though it would recover, might recover at a later age, and she really didn't want to have any ovarian insufficiency in the next 2 years. So we went on active surveillance, and so we followed her very closely due to the size of the tumor and the fact that she already had nausea, vomiting, and we were very fearful of obstruction symptoms, and it's regressed spontaneously. I did nothing to the patient other than scans in the beginning very closely, and with time, now I see her only annually now, and this thing shrunk from 12 centimeters to 3 centimeters on its own. So questions are multiple. Do you think there's any role for any major surgery when you have a huge tumor like this, which is causing nausea, vomiting, and a risk of obstruction potentially? And do you think that there's a role for systemic treatment, and which one would you use in that case? Also, a big question is the question of ovarian insufficiency, and how do you counsel patient about that risk, specifically in 40-year-old women who have not had any kids yet and do want to potentially have kids in the next couple of years at that age. Even though it's reversible, it's a real question specifically for those patients. And then would you have actually done active surveillance in this case? And I was very scared when we decided to do that with the patient initially because the tumor was actively growing, right? Are there factors associated with spontaneous regression? How frequently do you see spontaneous regression when you decide on active surveillance? Are there clinical factors, I don't know, like gender, location, size? There are different genetic mutations for different types of desmoids. Do you know if some of those desmoids regress more than others?
Any comments about this case?
So a great case that illustrates a lot of really important points. So first of all, I would not have offered this patient active surveillance as my first choice. It sounds like that was a patient-driven decision, but I think it would take perhaps even an unwise amount of courage to say that we could watch this patient on active surveillance as our primary recommendation, right? And it doesn't sound like that's what the physician here did. It sounds like treatment was recommended but deferred. But it goes to show that we don't know what's going to happen with these tumors. And so to answer your question, we don't have great predictive models. It's not age. It's not what the tumor looks like. It's not how fast it's growing. You know, I treat a lot of desmoid tumor patients, and I do not know who is going to regress and who is going to progress. There are lots of efforts to try to understand this better. You know, MRI tends to give us a better sense of what's happening in terms of cellularity of the tumor. But even there, we see patients that have very cellular tumors on MRI that still spontaneously regress rather quickly. And so a wonderful outcome in this case. And, one of the thoughts that had been out there for a long time was that, maybe some of these small tumors get better, but big desmoid tumors, probably don't shrink on their own. And that is not true. And I've also got a collection of patients with large desmoid tumors that were potentially not in dangerous locations. I remember a gentleman a few years ago who came to see me with, probably a 10 or 11 centimeter desmoid tumor in his flank, but he just swore up and down, doc, it just stopped hurting a month ago. And I feel like it's getting better. And we said, well, let's just bring you back in a couple months. And sure enough, he came back 3 months later and it was 30% smaller. And, 5 years later, we don't even see him anymore. But at the last scan, we were barely able to appreciate this thing. So it absolutely happens. I will make the comment, however, that for intra-abdominal desmoid tumors, for many of us, the threshold to treat is a little bit lower, just because that risk of complications of anatomical compromise is not as readily predictable. And so I think that many desmoid tumor experts would have said this is a patient that we should treat just because of that location.
So yeah, again, this was strongly encouraged to the patient, but it turns out she did really well. What about the issue of ovarian suppression with nirogacestat?
In these patients, we observed pretty early on that we were starting to see irregular periods. The protocol was then modified to try to capture reproductive hormonal levels and more carefully interrogate this. Important to recognize that ovarian toxicity is an umbrella term for a bunch of different things: premature menopause, missed periods, hot flashes, and it can be very difficult to sort of bound those. So probably what we're seeing is that for the duration of time that people are on treatment with nirogacestat, they are likely having some level of impact on ovarian function. All of the data we have to date suggests that patients who stop the treatment seem to recover that function. What we can't yet do is go to a patient and say, we know for certain that your fertility is not impacted. We don't know that to be true. And so I'm typically having a very detailed conversation with a patient about the ovarian toxicity side effect, saying we think it's reversible. However, we have not demonstrated that fertility is not impacted. And we still do typically have these patients meet with the fertility counselor prior to initiating therapy with nirogacestat, just so they can have a full understanding of what their options are.
All right, so let's go into this 39-year-old patient presents with abdominal pain.
This 39-year-old lady came in through the emergency room with worsening abdominal pain. And so a CT scan done at the local ER noted a pretty large mass in the left upper quadrant, about 11.4 by 10 by 9 centimeters. She eventually came to our emergency room about 3 weeks later saying this is getting worse. Her desmoid, which was eventually biopsied, had slightly grown. And so when I saw her in the clinic the week after, we had decided again that she needs to be on some sort of systemic therapy because her abdominal pain is getting worse. And based on the, DeFi data and the trial, we started her on nirogacestat. In that first month, she developed worsening headaches, nausea, vomiting, also diarrhea that was somewhat controlled. And she actually even came into the emergency room, I believe, once, just because she couldn't keep anything down. We actually decreased her dose briefly for a week, saying instead of nirogacestat twice a day, just do it once a day. But she was pretty adamant. She was scared she would lose the effect, as she said. And so she put herself back onto the full dose. But after that month, she said her symptoms improved greatly. She still had some diarrhea, but overall was feeling well. Her headaches got better as well. And even in that second month, she said her abdominal pain, she used to be taking opioids, basically didn't need anymore. And so when we finally restaged her 3 months later, she actually at that point already had a pretty significant reduction in that desmoid. Again, it was from around 11, 12 centimeters down to only about 6.3 centimeters. And her abdominal pain, like I said, was much, much better. So we continue on nirogacestat, again, just continuing to follow her with serial scans. The desmoid continued to shrink. Her headaches and diarrhea almost completely resolved. And so she's continued on this therapy. But I think a question to ask the experts is really, how quickly should we expect these desmoids to shrink? And then sort of piggybacking on that, how quickly should the symptoms improve? And then what other really common side effects should we be telling patients that they encounter? And then do they get better with therapy over time, or are there going to be something that they're just going to have to learn to deal with? And then maybe one last question. Her desmoid is slowly, the shrinkage is starting to get less and less, so it's sort of stabilizing. How long do we keep her on this? When do we stop this?
Any thoughts about this case?
Sure. So I think in terms of kinetics of response, because I think that's one of the key questions that Dr. Nakazawa raises here. So as we've discussed in other venues, we see symptomatic improvement in desmoid tumors quite rapidly after the initiation of therapy with at least nirogacestat. I'm not necessarily trying to sort of hawk that drug, but that's the place where we have the best sort of over time interrogation of patient-reported outcomes that tells us that in that drug, symptoms get better quickly. It's probably true for other GSIs. It's probably true for other therapies that are very active in this disease, but we've seen it demonstrated with Niro. And so having that be relatively immediate is typical. We see that very often. In terms of response on imaging, shrinkage of the tumor, that does come a little bit later, right? So the first thing that we typically see as an indicator, and this comes from some of the varegacestat data, is improvement in the T2 enhancement of the desmoid tumor on MRI. Now, we don't always do MRI for intra-abdominal desmoids because MRI can be challenging inside the belly, but it does give information that you don't get other places. So recommended imaging for desmoids is often CT for intra-abdominal tumors, and MRI is basically everywhere else because you do want that information when you can get it. But you'll see some improvement often in T2 enhancement as a next indicator, and then you see the tumor start to shrink. Time to response does seem to vary based on therapy. So for nirogacestat, it was in the range of 5.5 months on the DeFi trial. For sorafenib, I think it was closer to 9 months. And then, we don't have great numbers for this, but methotrexate vinblastine, which is a legacy therapy that we've used at low doses for desmoid tumors for many years and is still the preferred therapy in children, probably takes a year or more. Right. So that the kinetics of the response do seem to vary based on therapy. And I think, as we've said at other points in other conversations, one of the things that we might be looking for with the varegacestat drug is if it's a more potent GSI, does that result in a faster response? Do we actually see shrinkage more quickly? I don't know yet. Also important to note that time to response by RECIST is problematic in desmoid tumors because it's not terribly sensitive for a response. Desmoid tumors tend to grow often in a muscle in the direction of the fibers. So if you've got a 9-centimeter tumor, a softball in a patient's rectus sheath, and it shrinks to a pencil, but it's still 9 centimeters long, that's 9 centimeters by RECIST. That's stable disease. So we're probably lowballing the amount of benefit patients are getting when we quote those times. But the point I would make is it is clearly different from therapy to therapy. Getting back to the duration question, again, we do not know. And so for a patient who's tolerating it well, I think 1 to 2 years is not unreasonable. For patients that are having a harder time with it, I still shoot for at least 6 months and try to push to a year if I can. But it's arbitrary, and you sort of have to look at the patient in front of you and keep in mind, how dangerous is this desmoid? Is it in a bad spot, or is this just symptom treatment? And what's worse, the symptoms from the treatment or the symptoms from the disease? I think, key take-home points for management of desmoid tumors. I think point number 1 for people in the community is that you do not need to treat all desmoid tumors. In fact, it's probably, half or fewer that require therapy. So the first question to ask yourself is, do we need to treat this patient? And the decision is going to be based on whether the patient has bothersome symptoms or whether the tumor is in a location where there is some sort of pending anatomical compromise, bowel obstruction, vascular issue, something like that. That's point number 1. Point number 2, surgery is no longer the preferred therapy for desmoid tumors. And so when possible, surgery should only be undertaken on sort of in emergent circumstances or after really careful consideration. And so if that's being offered, I would suggest having the patient seen by a multidisciplinary team that takes care of these patients with some frequency, because it's really fallen favor out as the treatment of choice, because patients often don't feel better after a surgery and there is still a recurrence risk. And there's a whole bunch of evolving therapeutics. That's the third one. So for patients that for whatever reason can't tolerate or don't take nirogacestat well, we're concerned about those reproductive side effects. There's an ongoing study right now with FOG-001, recruiting patients with desmoid tumors. Varegacestat, the study has concluded, but we're waiting sort of the full readout of that phase 3 data and hopefully an application for marketing approval for that drug as well. So there's a lot happening. And so if you feel like you're having difficulty making a decision on your patient, reach out to an expert group that can help you with that, because most of these therapies, even if they're sort of pondered at a larger center, can be delivered in the community and probably should be.
Let's go into our next case. If the first case of Dr. Haddad of spontaneous regression was like really inspiring to me, this one, to be honest, was very, very scary. Again, young woman, 41 years old, but the scary part is she ended up coming for consultation for multiple surgical resections of the breast for desmoid and got post-op radiation therapy. And despite all of that, had progression. She also had implants, breast implants, so making it even more complicated.
This patient, unfortunately, was treated with several surgical resections for breast desmoids and margin positive. And she then had postoperative radiation. And despite all that, there was a relapse quite quickly after. And the tumor was growing and she had pain. And so we actually started nirogacestat. She had some toxicity, but very manageable mucositis and asthenia grade 1, like a little fatigue. And she had very positive response. And then she had been on treatment for 2 years. And so just recently, after 2 years of treatment, we decided to just stop treatment. She had continued positive response. Yes, she was tolerating it well, but mucositis and fatigue grade 1 are still important symptoms impairing her quality of life. Since she had no more symptoms from the desmoid, we stopped the treatment. So some of the questions I have for those patients is, how frequently do you see patients coming with multiple surgical resections in the community? And how do you feel about surgery for those breast desmoids as a first approach? And then second question would be, how do you feel about post-operative radiation therapy for those tumors once resected, even if margin positive? And then the second question is, when it's working, when do you stop, right? For how long do you continue treatment, knowing that, sure, she was tolerating it well, but she still had some level of grade 1 toxicity, which impairs her quality of life. And so when do you have those discussions with the patients? Knowing that she was also anxious to stop because she had had so much problems initially with 2 resection radiation therapy. So she also wanted to stay on treatment because she felt like we were treating her tumor.
So another great case, in some ways very typical. So, on the topic of breast desmoid tumors, that is a location in which we do see desmoid tumors. There's also been series reported of patients that have desmoid tumors associated with breast implants. And whether that's just a response to trauma, I don't know, right? But that's certainly been reported. It's not a huge incidence, right? But we do see it. I think that we also see patients separate from the breast location that just have desmoid tumors that are really refractory to surgical treatment. And like I said, in 2026, we're not offering a lot of surgery for desmoid tumors, but in the community, we still see this done. Even really fantastic surgical oncologists who trained 5, 6, 7, 8 years ago were trained to surgically remove desmoid tumors. And so this is a scenario that we do encounter with some frequency. And I think if this patient had come to our center, as they did and saw Dr. Haddad, we'd probably say that more surgery is not likely the solution to your problem. I think we've sort of maximally explored that. For these patients, and this patient had already received radiation, systemic therapy is a great option. And, we've done a fair bit of systemic therapy as primary treatment, but now this patient has been refractory to some local therapies. Also important to note, in the DeFi trial, many of the patients had prior local therapy like surgery. And so those patients seem to respond just as well as anyone else to nirogacestat. So I think the question of when you stop, again, there's no great answer to that question because none of these studies have been designed with a specific duration in mind. Patients are allowed to continue therapy for as long as they are benefiting, similar to what you do with a study in a metastatic unresectable cancer, even though desmoid tumors aren't exactly that. They're not, frankly, malignant, and they can sort of stay stable off therapy. So, I typically would say it's time limited, right? So as I've said in the past, 6 months to a year as a starting point. And, once you get past about 2 years, sort of, if you haven't seen any change in the tumor, saying, hey, let's stop and see what happens is my typical approach. We've looked at other signals to try to get a sense of what's happening with the tumors. So desmoid tumors that are very cellular tend to be bright on T2 MRI, and that gives you a sense of what fraction of the tumor is bright versus very dark when they're sort of these fibrotic treated tumors. And so, some of us will use the amount of T2 enhancement in the tumor as maybe a guide to say, okay, well, this tumor is sort of mostly treated, so let's stop and see what happens. But that has not been validated, right? There has not been a study of using T2 enhancement in a rigorous way to determine whether a patient is done with treatment and then showing that is somehow correlated with what happens to that patient afterwards. So it's still Gestalt. I think 2 years is a reasonable duration of therapy in a patient who's tolerating treatment well. In a patient who's having a harder time, you may stop sooner.
This patient had, I guess, minimal, but did have mucositis. Also was thought to have fatigue related to treatment, like she thought it was.
Yeah.
Do you see this, and how do you manage it?
Yeah, so stomatitis is one of those side effects that is absolutely reported with gamma secretase inhibitors across the board. It's a class effect. And, it's oral care, xyloxolone, things like that to try to minimize the symptoms from that. Dose reductions for nirogacestats, there's one dose reduction from 150 to 100 milligrams twice daily, which often will help as well. Asthenia is also there. We do see mild fatigue. I think in the DeFi trial, it was rare that we didn't know who was getting active drug and who was getting placebo, despite the drug being relatively well tolerated. You definitely had the sense that people felt a little bit different. And, honestly, the place where we really saw that is when you stop patients, they are often surprised at how much better they feel off therapy. And to me, that just drives home the fact that this is not intended to be indefinite therapy. This is meant to be done for a period of time, and then you stop.
You mentioned the issue of surgical trauma. And, I heard cases sometimes where prior abdominal surgery, and it looked like maybe it was where the surgery was. Is there a correlation with, you brought it up with the breast, is there a correlation of surgery and localized desmoid?
So I think in the FAP patient population, I think it's pretty clear that there probably is. We see a lot of intra-abdominal desmoids in patients after their colectomies, for example, right? In sporadic desmoid, it's hard to know, right? There is a mutation here that has to exist. And then does the wound healing response after trauma then sort of cause this to grow? It may be the case. The reason that I'm a little careful about sort of saying that it's definitely happening is that, I take care of a lot of patients with soft tissue sarcomas in various parts of the body. It's not uncommon for a patient to come to me and say, well, I traumatized my arm and now I've got a sarcoma there. And, sometimes it's just that's what they sort of associate it with and sort of remember that insult rather than actually being causally associated. For desmoids, I think there may be some there, but I don't think it's been rigorously demonstrated. Let's put it that way.
So let's hear the next case from Dr. Nakazawa, a young woman treated with local therapy.
This is a 34-year-old lady, again, very healthy, no other past medical history, who is noting this enlarging sort of mass on her right lower abdomen, developing some pain with ambulation. And she was working as a physical therapist. So as she was working with people, she could really feel it and was starting to really impact her quality of life and her job. And so when we got the MRI done, they found this 4-centimeter mass in the right pelvis. So at that point, we had recommended nirogacestat to be a good potential therapy. She was pretty much against the thought of taking that. And, we mentioned the other drugs like sorafenib and some of the chemos, and she was again against that. So then we brought up, are there any local control options? And at that point, we were talking about radiation and cryoablation, and she had favored cryoablation. So, we consulted our IR colleagues, and she had an ablation done. The only complication that she had from that was there might have been a slight hematoma that developed. She had downtrending hemoglobin, but that stabilized and otherwise was uneventful. And so when she had that CT scan just done right after, it significantly enlarged after the ablation. Got up to almost 7 centimeters from the beginning 4 centimeters. She said her pain got really bad, but over the course of about the month or so after, it steadily got better and better to the point where she pretty much was saying that she doesn't really have any pain anymore. And so when we saw her 4 months later after the procedure, again, not on any sort of systemic therapy, the desmoid was continuing to reduce in size. So I think a good question to ask the experts is really what patient factors and tumor factor, desmoid factors go into whether or not you should proceed with it. IR cryoablation or radiotherapy if you're considering some sort of local treatment options. I think that a particularly important question for this patient too was understanding this ovarian suppression mechanism and, at what point would they expect this to be potentially permanent or not? If she's on this, when does that happen? If she stops therapy with nirogacestat, how quickly would her ovarian system return to normal? And sort of ultimately, what percentage of women this age do you think will encounter this side effect that may be very important to them?
Any comments about this case?
So the abdominal wall is a place where cryoablation has become a pretty favorable option for some patients, right? So one of the concerns used to be that a tumor in the abdominal wall may actually be immediately adjacent to bowel, or in this case, looking at the images, potentially the bladder. They've developed techniques to separate those structures now. So typically what they're doing when they do cryoablation is they're insufflating air into the abdomen to separate the bowels from the abdominal wall, and then they treat the tumor. And so the abdominal wall is a location where I often think about cryoablation as a potential option for a patient. And so, and in this case, I think a really nice one. And so we do prefer cryoablation sometimes in patients where they have tumors that are anatomically amenable to that treatment, because it's a one and done therapy, right? You treat the patient once. They don't have to be on a medication for 6 months or a year or 2 years or whatever we ultimately decide that it's going to be. And so I think potentially a nice fit for this patient. It looks like afterwards there was still some residual tumor, and that's typical. I mean, cryoablation typically doesn't cause the tumor to disappear with no residual defect. You expect to see something there, which may continue to shrink over months or years. And so the question is that sort of residual finding on imaging active disease, or is it just what's left over after this has begun to scar down from cryoablation? And so with any treatment for a desmoid tumor, I'm not usually saying, okay, we're going to do this, and if we still see something, we'll go to the next thing. It's usually we're going to do this treatment, and if the tumor grows, or if symptoms get worse and we think it's due to progression, then we'll go to the next treatment. So there's no neoadjuvant systemic therapy to get it ready for cryo. You would do the systemic therapy. If the tumor responds great, then you leave it alone, because very often it'll just continue to get better over time, even after you stop the treatment. So you don't have to roll right into the next therapy. So for her, if this residual disease or residual finding, I should say, that she has on imaging is associated with worsening symptoms, then I think trying a second desmoid treatment, whether that's more cryoablation or nirogacestat or sorafenib or any of the other medications that we have to treat this disease, all of those would be on the table. But the first thing I would do is verify that we actually think that this is still active. A couple of really important points. One, we don't know what the optimal duration of therapy is. And so when we're starting a patient on treatment with most of these drugs, usually what I'm telling a patient is, let's plan on at least 6 months, maybe a year, and then we'll see, right? It's not we're going to stop at that point. It's let's see how you're tolerating it. Let's see how your tumor is responding. I don't expect you to be on this medication for the rest of your life. However, there are some patients where it is difficult to stop. And that's what we see. So, there have been some early efforts to start to define this. There was a study in Europe done called the SORASTOP trial, where they just did that. They did a defined duration of sorafenib and stopped and tried to see how many patients required resumption of therapy. The answer is actually quite few, but there are some. And then the other thing that we don't know for most of these therapies yet is if you stop therapy and then 6 months later have to start it again, does it work as well as it did the first time? We don't have that data in desmoids yet. And it's something that the community really wants, right? So a discontinuation and resumption type study. But for a patient like this, what I would say is our expectation would be that we treat your desmoid tumor for a finite period of time if we were going to use a medicine. And that finite period of time is a discussion between the physician and the patient. But like I said, I set the stage for at least 6 months to a year. And then we stop and we see what happens. And very often that goes quite well. We've stopped a lot of patients who were treated on the DeFi trial once the drug was finally approved. And it's been a very small minority of patients that I personally treated that ultimately required retreatment.
This concludes our program. Special thanks to Dr. Ratan, and thank you for listening. This is Dr. Neil Love for Practical Management of Desmoid Tumors.